is a bicornate.
Okay.
In my opinion, this is bicornate uterus. Okay, but see the answer
Okay.
here: unicornate uterus with contralateral alimentary horn. How come? I think it little bit not a logic answer. Okay, but anyway, if you tell the examiner these details, he will pass you. No problem. Okay. Thank you, doctor,
Okay.
so much. The
Thank you so
answer
much, sir.
again of this case, my colleague, this is, in my opinion, this is a bicornate uterus with rudimentary, rudimentary horn. Okay, plus dorsal pancreatic agenesis. Thank you, doctor, so much. Candidate,
Hello, sir.
hello. Request control. This
Um,
15-year-old male patient presented with seizures and the psychomotor retardation. Request
sorry, sir.
control.
I don't have a mouse, so can you scroll for me, please?
Okay. Okay.
So I'm presented with the sagittal cuts of axial cuts of T2-weighted MRI of the brain of a young age patient present with psychomotor disturbance and history of seizure. The most striking finding is obvious asymmetry in the volume of both cerebral hemisphere, with decreased left cerebral hemisphere volume,
Yes.
and associated with dilatation of the ipsilateral lateral ventricle, abnormal high signal intensity involving the cortex of the left parietal and temporal lobe, and associated thickening of the calvarium on the ipsilateral side. So I
Okay.
want to scroll through the other sequences and including the T1 and the flare sequence because of the
This
age
is the
of the patient.
only. This
Okay,
is
so
the only sequence. Hmm?
because of the age of the patient, young age, history of seizure, and the presence of hemicerebral atrophy and thickening of the calvarium, my
Yes.
provisional diagnosis is Dyck-Davidoff-Mason syndrome, which
Excellent.
consists of ipsilateral cerebral hemiatrophy and thickening of the calvarium. Other less likely differential diagnoses include Sturge-Weber syndrome on the left side or left side Rasmussen encephalitis. But
Excellent. What is?
yes.
How could you differentiate the three differential diagnoses from each other?
Well, the Dyck-Davidoff-Mason is characterized by the presence of calvarial bony thickening on
Excellent.
the site of involvement,
Yes.
while the Sturge-Weber syndrome is characterized by ipsilateral choroid plexus hypertrophy and angiogenesis. When I see that there are multiple enhancing vessels on the post-contrast images, and I see
Exactly. No, no. One
cortical
second. One second.
calcification.
Where is the exact location of Stag-Weber syndrome enhancement? Exactly. Excellent.
Leptomeningeal angiomatosis.
Yes, not angiogenesis, يعني the correct
Sorry, angiomatosis. Yes,
angiomatosis. Because
yes.
the alternative, what is the alternative name of Steiger-Weber syndrome?
Uh, it is angio. I'm
It
sorry,
is
I cannot remember.
angiomatosis.
It is angiomatosis. Yes,
Yeah,
hemifacial. Uh,
encephalo trigeminal
yes,
angiomatosis. Okay,
encephalotrigeminal angiomatosis.
angiomatosis. Okay,
And the
okay.
third differential diagnosis, Rasmussen encephalitis, is
Yes.
characterized by the atrophy of the cerebral hemisphere and
No, no. What is the differential point between Rasmussen encephalitis and Davidoff syndrome?
the
Only
absence of
one word.
calvarium thickening.
This is one point. Second point, the Rasmussen is more focal, almost
Mm.
affected one lobe of the hemisphere, almost.
Okay.
But the
Hmm.
Davidoff, as you see here, almost affect whole the hemisphere. See here, the whole hemisphere is atrophied.
Yes.
Could you, doctor, you are very brilliant. But another last question. What is the underlying etiology of this Davidoff-Madison syndrome?
I think it is an in utero uh,
Excellent.
involvement of the internal carotid artery, uh,
Excellent.
which
Vascular
yes,
insult. Vascular insult.
Vascular insult. Vascular
Yes,
insult.
thank you,
Yes.
doctor, so much. You did very, very
Thank you
well.
so much.
So, my colleagues, this is expansion of the diploid space. This one. Why? Because the black one, this cortex, and this cortex. So this is expansion. Why this expansion occur? Because of the atrophy of the left. Look here. There are significant atrophy of the left hemisphere associated with this encephalomalacia. I think very obvious for all. Associated with ventricular dilatation. All this sign affecting the whole left lobe. So put Davidoff-Madison syndrome on top of your differential diagnosis. Then other differential diagnosis, like the doctor enumerate, Rasmussen encephalitis or Steg-Weber syndrome. Thank you, doctor, so much. Next candidate.
Yes, hi, Doctor.
Hello. Hello. Request control, please.
Okay. Requested.
Go on. My colleague, today collection of cases is very, very similar to the exams. Fluctuate between 1 second. Fluctuate
Sorry.
between easy cases, typical, film age, everything. This is one of the most typical exam scenario. Go on, doctor.
Yes, may
Doctor,
I know the
this
history, please?
this patient is 50-year-old female patient complaining of abdominal pain. Go
Okay,
on.
I'm presented with CT abdomen bulbous with contrast axial cuts for a female
Doctor,
patient.
your voice is very muffled.
Okay, can you hear me now?
Yes.
Okay, this is axial cuts for CT abdomen bulbous with contrast for a female patient presented with abdominal pain. I will take a look from the upper cuts to the lower cuts to then I will give my comment.
Mm-hmm.
Uh, okay, I can see here there is a focal area of fat stranding within the left upper quadrant.
Yes. Focal or localized? 1 second. Focal or localized?
Localized, sorry.
Focal means something small, okay? And it is better to describe side solid organs like this. But here, localized, okay?
Localized, yeah.
Yes,
And I can see that there is a break in the anterior abdominal wall. This is going up to the skin. Is there any operation before surgical history?
yes, yes. The patient just underwent an operation 2 weeks ago.
Okay, so as a patient underwent operation 2 weeks ago, and there's underlying localized area of fat stranding, and I think there is
Then,
fluid collection. This may be intra-abdominal abscess or focal collection or localized collection. Sorry, I would like to check it's going up. I think there
doctor,
is a foci of air seen. Yeah.
okay. Look at the overall density of this localized abnormality. Overall density.
It's high dense than the fluid.
No. Oh, okay. What else? The density
Fatty,
here. Yes.
fatty density.
So the patient is post-operative, and this is almost of fatty, but not
Mm.
not a normal fat. So what
Yes.
happened here?
Uh,
What is
not really sure.
most common pathology or
This is maybe
complication?
omental
Yes,
infarction.
yes, excellent.
Omental,
What
yeah,
else? Yeah,
omental fat infarction. But
Yes,
here,
go.
this is a collection, right? This is a
Whatever. Okay. What happened? Again, go down.
down. Okay.
Trace the colon, please. Trace.
Okay. This is the rectum. I will go up this sigmoid.
Again. This is the rectum. Up,
Mm-hmm.
up, up. What happened here?
Uh,
What happened here?
this is surgical clips.
Okay. Can you see
This is
rest of the? Can you see rest of the colon?
no, no, I can't.
Up.
This is
So this is the
so the
status
patient
post.
had a colectomy, post colectomy.
Yes. And what happened here?
This is surgical clips as well.
Okay. 1 second. 1 second. 1 second. See, this is the surgical.
Mm.
Connect one small bowel with another small bowel. Okay. So give me a conclusion, please, and the diagnosis. Hello? 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 Hello?
Hello, yes, doctor.
Sorry. Internet
No
drop.
worries.
Okay. So give me a conclusion, please.
So I think this patient has underwent colectomy, left colectomy,
Yes.
with complicated mental infarction. So,
Yes. Yes.
and I would like to check also the vessels, the vasculature, and sagittal view.
Thank you, doctor, so much. This is a case of this is post-operative, and many examiner will not give you all the details. Why? Because see here, there are median laparotomy and
Mm.
there are colostomy, okay,
Colostomy, yeah.
and there are surgical clip. Many signs. If I will examine, if I will start from down, I will follow from here, okay, up. Where is the colon? No colon. No colon. Just
Mm.
they close this in. And all of this are small vowel. Go up. No, see here, no any ascending colon. But here we find abnormal fat, and the patient is post-operative, so we must put number one, mental infarction in the first differential diagnosis. Number two, leakage. Why? Because there are anastomosis here. There
Mm.
are a loop and there are a loop. Look here. This is the stomach. Follow the stomach. Go down. This is the duodenum. This is the duodenum. Okay. Where is the anastomosis here? Between the small bowels. Okay, my colleagues. And this
Mm.
is the mesenteric fat. So this is either a leakage or either winter
Oh,
infarction.
I'm
But
in the infarction.
there are no any pneumoperitoneum. So you can exclude leakage. Thank you,
Mm.
doctor, so much. This patient must
Thank you.
have a malignancy in the colon, and this is the post-operative. Next candidate.
Assalamu alaikum, sir.
Salam. 30, request control, please.
Yes, sir.
30 year
Question.
old female, 30-year-old female patient presented with cough for 3 months. She didn't respond to the treatment.
So I've been presented with the axial CT post-contrast images. I would like to
Yes.
scroll first and then give my comments.
Yes.
Scrolling very slowly, but Sir, I can appreciate free fluid in the cul-de-sac,
Okay.
in the pelvis, as well as around the
Okay.
liver.
Okay.
The uterus appears grossly unremarkable, as well as the bilateral adnexa.
Okay.
Sir, no pathology, gross pathology in the noted in the gut or kidneys or
Mm-hmm.
whatever. The suprarenals are okay. So she's having cough and she, sorry, can I?
Cough not responding to the treatment.
Okay, sir, I would like to review the ovaries again because sometimes,
1 second. 1 second.
yes,
What
sir.
is the finding here?
Sir, because I would like, because the cough is normally sometimes associated with fibromas of the ovary. So I would like
Okay.
to see
Tell me what did you find here
so
in
I
this
found
exam?
STDs.
Aside.
Yes, sir.
Okay. What is your next step?
So I would like to go for MRI, ultrasound, and then MRI.
Okay, but the
Uh,
patient has cough. Do you assess the cause of cough?
yes, sir. I would like to do CT chest. Yes, sir.
Okay. Yeah, go on.
Sir, I found in the I can appreciate a collapse consolidation in the right middle lobe,
Okay.
linear atelectasis.
Okay.
The bilateral upper lobes appears unremarkable,
Yes.
as well as if I go down.
What happened here with
There's
this
some
collapse? Yes.
so there is collapse and there is a dilated bronchi.
Okay.
Yes,
If I
sir.
show you this one,
No,
is a
sir, there is
static
a
image.
vertebra plana, collapsed
Yes.
vertebra. Yes,
Yes.
sir.
Collapsed vertebra. Okay. And the patient then developed neurological symptoms. CT scan was done.
Sir, I cannot. Maybe the scroll. I cannot scroll. Sir.
Static. This is
Is
static image.
sir bilateral posterior. Not posterior. The white cerebral white matter. So there is accentuation of the gray-white differentiation more in the occipital lobe. Apart from that, I can see a linear area of hypodensity that is seen in the right parietal region with the loss of gray-white differentiation with associated hypertense area in the adjacent cortical region.
Excellent. What's your next step?
Sir, MRI brain. And also some calcified speck, which is noted in the intraparenchymal. So I have left the mouse. Yes.
Okay. Look here. Static
Yes, sir.
image.
Yeah, sir. Sir, it looks like a hemorrhagic foci with the perirenal edema, and it is quite dense, black, appears like a cavernoma. But I would like to review it on further post-contrast images as well as on T1 and FLAIR images. So in the post-contrast, there is peripheral enhancement, so the cavernoma is probably ruled out. So there is intense enhancement with perirenal edema, and it is a well-defined the focus with the low signal in the center. So it can be a hemorrhagic met.
Okay, what else?
Sir, it can be
See, what is the
yes.
location of this lesion?
Sir, it is in the parieto-temporal region, sir.
No, I'm not asking about which lobe. What is the exact location?
Sir, subcortical white matter.
Okay.
Gray-white.
Gray-white matter junction.
Yes,
okay,
sir.
Very excellent. So this location What's its significance?
So METs are more common, and this is
Okay. And what else? This
it's a
is
watershed.
no, this is not outer shadow. This is the site of blood-borne pathology.
Yes, sir.
Okay,
Okay.
gray-white matter junction here, site of blood-borne pathology. Try to integrate the whole finding of abdomen, chest, and the brain. Patient has cough and has chest pathology, has ascites, and has this peripheral enhancing lesion.
So, sir, it can be some infective lesion, most probably
Okay,
tuberculosis, as lead
excellent.
to peritoneum
Look
with the
here.
lung and as
Look
with the
here.
tuberculomas in the
This is,
lung, in
thank you,
the
doctor, so much. Thank you so much. Look here, my colleague. This is a low T2 center, very characteristic of tuberculoma. What happened here? I will repeat the history, the story from the beginning. We start with abdominal CT. The only finding is pelvic abdominal ascites. Okay, and the some enhancement may be related to ovaries, maybe infection. We don't know. There are no clue to be ruled out or to indicate something. Then at chest CT, we're done. There are also abnormality. Really, till now, no any conclusive finding. This is just collapsed lateral segment of medial, frankly. Okay. And what happened here? Some bronchiectatic change, nothing specific. And then we did CT. The CT here, slightly hyperdense lesion surrounded by edema. And then after MRI, the clue in the T2, dark, dark. It may be calcified or hemorrhage, but enhanced. So tell the examiner both possibility. It looks like blood-borne pathology. I will put metastasis versus infection. Even if you didn't tell TB, I think the examiner will pass you. But better to tell him a TB. Why? What is very common in RCR exam to be multisystemic like this? TB. Okay? This is a multisystemic TB, isolation of the patient, screening of the contact, antituberculous, and informing of the authority, the public health authority should be mentioned. Should be
yes.
mentioned. Thank you, doctor, so much.
Sir, there's one more point I wanted to tell. Sir, in the bicornuate uterus, both the cornu of the uterus must communicate with the single cervix. But in our case, that one we had, the one was non-communicating. It was written. There was no communication with the other horn. So it was a unicornuate with a non-communicated rudimentary horn because it was not following the condition of communication with the cervix or the vagina.
See no problem يعني no problem. This exam not يعني overall the radiology is not a pathology. If you told the examiner, you are correct by the way. If you told the examiner, doctor, there are two uterine cavity, one of them is larger than the other one. There are one cervix. Plus, you are in the correct pathway. So I told you, in my opinion, this is bicornuate with rudimentary. The radiopedia mentioned this is ionic cornate with the other one is rudimentary. Okay, I will accept both of them. But the
If
most
we do not
important,
mention the proper classification, it will not deduct the marks. You suggest that, like if we are not up to the very accurate diagnosis, even if we say that this Mullerian abnormality and further we classify it as much as you can, it will still we can get the case, right?
at least you are in the correct pathway.
Yes, sir. Okay, sir.
Yeah, if I am examiner and you pick up the finding and you tell me everything and you are not sure, like me, for me, I'm not sure the rudimentary one connected or not to the uterus. Really, I'm not sure. I examined it too many times yesterday and today, and I'm not sure if there are or there are not communication with the cervix or not. This is not a big deal. Okay, my
Okay.
colleagues, not a big deal.
Yes, sir. Thank you. Thank
Thank
you.
you, doctor, so much. Next candidate.
Yes,
Next
so hello.
candidate. 30-year-old female patient with cough.
Yes, sir. Hello.
Yes, doctor. Request control, please.
Okay. Okay, I did.
One second. Yes.
I think it's not. Yes. Okay. So I'm presented with CT of thorax, axial sections, lung window. First, I like to scroll the images, and I will start describing my findings. Um, I can see that there are bilateral, patchy, peripherally seen reticular opacities. Um, there is mild pleural-based reticular thickening seen peripherally in the subpleural region along both lung fields.
Mm-hmm.
As I go down, yes, the bilateral lower lung lobes are more affected. The bilateral basal lung fields show cystic changes on the background of some ground glass changes and some honeycomb formations. And the findings of lung are showing epicobasal gradient and are suggestive of underlying interstitial lung disease. More likely, it's NSIP. I can also
Mm-hmm.
see that there is marked dilatation of the esophagus with some yes, there is marked dilatation of the esophagus with some food particles seen in it. So I'm concerned about any underlying connective tissue disorders such as scleroderma. I like to see if there is any previous imaging available for comparison, and will like to see the clinical notes. Does patient have any history of scleroderma or systemic sclerosis? And keeping in view the lungs, I'm also concerned about developing pulmonary arterial hypertension, for which I will like to see the pulmonary arteries on the mediastinal window.
If
Otherwise,
if I told you the patient have some abdominal discomfort, what will you do next?
okay. My second differential could be of a patulous esophagus with which could be in the case of if the patient have abdominal symptoms, then I would like to go for a CT of abdomen to look for the status of intestines.
Okay.
Um, because there are findings of hidebound appearance of the intestines in the scleroderma. Mm, okay, I can see that there is marked dilatation of the bowel loops. These are dilated small bowel loops and filled with the fluid.
Mm-hmm.
I'm trying to look for any transition point. I'm trying to look at the ileocecal junction. There is also evidence of air locules in the cecum wall, which is raising concern for pneumatosis intestinalis, which
Mm-hmm.
is also a finding in the cases of scleroderma. I like to see the corneal image if available to look at the ileocecal junction and bowel loop.
Mm-hmm. So, what's your differential or final diagnosis?
Yeah, keeping in view the findings of abdomen of dilated fluid-filled intestines and also some wall thickening with enhancing mucosa, I'm thinking on the line it's likely due to hidebound appearance, and I'm thinking on the lines of scleroderma and systemic sclerosis. And I will convey the findings to the referring clinician as this patient needs urgent decompression because of the dilated bowel loops. Um,
Yes.
yes, the ileocecal junction. is unremarkable, but there is also distension of the dilatation of the ascending colon and transverse
Doctor,
colon.
what is the cause of esophageal and the bowel dilatation in case of scleroderma? What is the pathology?
Um, yes, the underlying pathology is due to abnormality in the mesenteric plexus, due to which it is unable to constrict, and there is
No, no, no. One
patulous
second. One second.
esophagus.
One second. If the
Yes.
esophagus has abnormality in the mesenteric plexus, it will lead to another disease. It will lead to chalasia. Is correct or not?
Acacia.
Yeah. So
Yes,
the
yes.
cause here is not to infiltration of the mesenteric venous plexus. What is the cause?
Because of the atrophy of smooth muscles,
Yes,
because it affects the
infiltration.
smooth muscles contractility.
Yes, yes. Infiltration or affection of the smooth muscle. Okay. So we see this gross
Yes.
dilatation with GIT and the lower end of the esophagus. Thank you, doctor, so much. A classic case of multisystemic scleroderma. Okay, my colleagues, see here. I think no need to explain the chest. All of you know the non-specific interstitial pneumonia here, plus this esophagus. Okay, here the surprise here. What happened here? There are no classic hide-bound appearance, but just bowel dilatation. Okay, in correlation with the chest finding, it is a scleroderma finding. Thank you so much, doctor. Next candidate.
Thank you, doctor.
Yes, sir.
Doctor, this patient has severe pelvic pain. Request control.
Sir, sorry, I'm unable to scroll. Can you please
Okay.
scroll for me?
Yes.
Okay. Sir, is the patient male or female?
Female.
Female patient with the pelvic pain. So I could appreciate a complex heterogeneous mass located
Mm-hmm.
located in the pelvic region, and
Mm-hmm.
mm, sir, I would like to see any color flow images, and
Mm-hmm.
I think this is I think is it spleen, heterogeneous spleen?
No, this is the pelvis.
Okay, so there's just a complex adnexal mass, maybe, and I would like to correlate with the CT or MRI pelvis if available.
Okay.
Sir, I'm provided with MRI pelvis of the patient, and I could appreciate a heterogeneous mass located in the cervical region. So please scroll down one for me. On the T2 images, I could appreciate that this mass is slightly hypertense. However, it is involving the stroma, and no signal of stroma is not visualized. The vagina seem fine to me. So can I have look at sagittal images? Yeah. So I could appreciate that there are multiple additional fibroids in the uterus, and this mass appears to be arising from the cervix and prolapsing into the arising from the endometrium and seen prolapsing into the cervix and
Excellent.
then vagina. I would like to
Excellent.
see a post-contrast image as I'm thinking of any submucosal fibroid or a polyp, endometrial polyp.
Mm-hmm.
So I
Excellent.
want I like to see the post-contrast images, please. So it is showing I'm provided with the post-contrast images. I could appreciate multiple subserosal intramural fibroids with the previously seen prolapsing mass showing intense homogeneous post-contrast enhancement. So considering the imaging appearances, I'm thinking of prolapse submucosal fibroid, and I would like to convey my findings to the primary and I think I'll need an IR consult for it, or maybe they'll do some I'll refer the patient to the gynecology MDT.
Anything else, doctor, here?
Sir, I could see that there is some fluid in the endometrium, additional
What about,
fibroids.
doctor? What about
These are
those?
Sir, I told them that there are multiple
Really?
additional
I'm sorry. Doctor,
subserosal fibroids.
thank you, doctor. Thank you, doctor. You did very well. Very well.
Thank you.
This is a large endometrial, see, large endometrial polyp. How could we know it? Look here, connection. And don't concentrate too much about this fluid. Some pretend fluid or blood because there are fluid level, but the fruit is here. See, the origin from here, and it has an enhanced vascular pellicle. Typical an endometrial polyp, but a typical size. This is the vagina, by the way. Okay. Thank you, doctor, so much. Very well. Next candidate.
Yes, doctor.
Team, I collect till now many typical pathology in a typical location. So I'm telling you today cases very near, very simulating. So simulating the FRCR normal exam. This patient has left-sided mandibular pain.
Okay. I've been provided with.
By the
Doctor, can
way,
I?
I sometimes hide the history, because some histories are very indicative of the diagnosis. And by the way, it may be a scenario in the exam. Sometimes you ask the examiner, what is the history? Pain, pelvic pain, something like this. Go on, doctor.
Okay, I've been provided with axial cut for the head and the neck with contrast for a patient complaining of left mandibular pain. Just I will scroll and then I will comment. Okay. Okay. I can see that there is evidence of hypodense lesion noted within the left aspect of the level of the body of the mandible, and it's surrounded with marginal enhancement. Okay, I can see that there is evidence also of multiple lymph nodes surrounding. Okay, I can see that the blood vessels within the neck appearing normal. Okay, the external carotid and the internal carotid. Okay, only multiple enlarged lymph node, and this enhanced lesion with central necrotic or central necrosis.
Okay.
Just I want to look for the veins, the submandibular veins and retromandibular veins, and the internal jugular vein within this region also.
So,
okay, I can see that the blood vessels, the blood vessels appearing normal. Also, I want to look for the bone here, just to know if there is any connection with the bone or no, or it cause any destruction of the bone. Can I open the bone window?
Yes, sure.
Okay. Okay. The bone appearing normal.
Okay.
I couldn't see bone destruction. I couldn't see any extension also to the brain parenchyma. It appeared normal. Okay. So all the tooth also appearing normal, apart from this only
dense or lucent lesion within this teeth, which could be tooth caries or something.
So what's your differential diagnosis?
Just I will have a coronal view only to look for the final, and then I will.
No
It
need
appeared
for
to be
corona.
abscess. It appeared to be
Yes,
abscess.
very
It
easy.
appeared to
Yes.
be abscess in the left
Okay.
aspect of the mandible, maybe related to this tooth caries at the tooth. I will convey my finding for the referring physician for the ENT for this tooth extraction and some abscess drainage.
Yes.
Okay.
Where is the location? You didn't talk about the location.
Here, okay. Okay, it's related to the left body of the mandible in the left angle.
Not the left angle. See the left angle here.
Oh,
This is-
okay. It's extending even to here. So,
No, see, very easy. What is this?
this is sorry?
Submandibular. Submandibular
Yes, this
gland.
is the submandibular gland.
So
And
this is the region of, what is the name of this region?
submandibular
Submandibular.
submandibular triangle.
Yeah, okay. This is a submandibular abscess, or it may be in the mastocytory space.
Okay.
See? Okay. Both are correct. Thank you, doctor, so much. My colleague, my advice to you, trust in yourself. What is in your mind is the best answer. Okay? This is an hypodense area, okay, surrounded by thickening. See the thickening here, affecting the masseter, affecting all the tissue here. And the question here is this abscess, peripheral enhancement. What is the name of this area? Trace first the submandibular gland. Oh, this is the submandibular gland. Okay, this is out of the tongue. Okay, and this is the mandible. If you told the examiner this is a submandibular region, he will be happy also. No any problem. Thank you so much, doctor. Next candidate.
السلام عليكم.
Salam, request for doctor. 70-year-old female patient with cough, presented with cough. Go on.
The age again, please.
Can you request control, please?
The age again, please.
1 second. 70-year-old female patient. Go on.
Okay. So I'm presented with axial CT scan of the chest with IV contrast on mediastinal window for a 70 years old female presenting with cough. I would like to have a general look before starting my comments. It's actually lower chest and abdomen and pelvis. You can see that there is a large mass on the right breast in the lower upper quadrant, peripherally enhancing, abutting the skin and the anterior chest wall.
Yes.
Associated with skin thickening and fat stranding of the right breast. The left breast appears unremarkable. You would like to check for the lymph nodes. Looking especially for the internal mammary groups and the axillary groups on both sides. Yes, there are multiple enlarged right axillary lymph nodes, highly suspicious for metastatic nodal disease. This mass is highly suspicious to be a breast cancer.
No. One second. Highly suspicious or almost, or maybe possible pneumonia. This is a CT. See, take care. This is a CT. At least tell the examiner this is this is aggressive mass. If you in doubt, this aggressive mass.
Okay. So aggressive mass of the right breast associated with metastatic right axial lymph nodes. The internal mammary group, the mediastinal lymph nodes, posterior mediastinal lymph nodes, the postophrenic angle groups are clear. Regarding the vessels, they are patent, no central pulmonary embolism. You would like to check for. I would like to check for the abdomen, looking for other metastases, and I will come back to the lungs. The patient is presenting with cough. The liver shows no abnormal enhancing lesion. Kidneys, adrenals, clear. Mesenteric lymph nodes are not seen. Okay, so adnexa are fine. I would like to check the lung window, looking for pulmonary metastasis that could explain the patient presenting symptoms. Just few air-filled pulmonary cysts. Areas of mosaic attenuation suggesting of small airways or small vessel disease. Subsegmental atelectasis on the right lower lobe
Okay.
or in the lung bases on both sides.
Choose,
No suspicious lung lesion.
choose the last window that I can give to you.
The
And
last
why?
window.
Hmm.
This one?
Why? لا. No, tell me first. Which one and why?
Okay, the last window, you mean the last sequence, the sagittal abdomen pelvis?
Okay. Sagittal. To rule out. Why you want sagittal? Why?
Okay, I would like to check for
Hmm.
osseous lesions
Okay.
on the sagittal. Okay, the lymph nodes are also seen on the sagittal along the vessels. My concern is about the lung, patient coming with cough. I would like to check the whole of the lungs. The previous serial only shows mid and lower part of the lungs.
Doctor,
Yes.
1 second. I give you a misleading history or a vague history. This is not
Okay.
a lung case.
Okay,
This
fine.
is a chest CT. If I told you, doctor, the patient has left right breast mass and this is a chest CT, خلاص, the exam lose its value. Why? Because this is a film edge exam. This is the purpose of this exam. This is a film edge. Why? The examiner want to see, to evaluate you. Are you searching in all parts of the exam? Or just this is a lung or chest? I will see the lung, normal, finish. Like this.
Okay, fine.
Okay?
Fine.
Okay.
So in my routine practice, I would like to check for the bones, checking for
Okay, there
metastasis. I can
are
see that there are multi-level vertebral compression fractures with
do you think
retropulsion.
one question? Could you differentiate or give me a clue? This number three, L3, the compression, the cause of compression collapse here. What do you think is the cause?
Okay, at this level, to me, it is suspicious for
Why?
malignant process because
Why?
there is retropulsion.
Excellent. Thank you. Thank you so much. It may be due to metastasis. Why? Look at the posterior aspect, convex. Increase the volume here, so convexity under. Thank you, doctor, so much. It was a case of right breast cancer. I think this is very clear. You can see, doctor, it looks like breast cancer. Why? See, impossible to exclude breast cancer or to be worried about breast cancer in this skin edema and malignant lymph nodes. See, malignant lymph nodes. Thank you, doctor, so much. Did very well. Next step after CT staging is bone scan or PET CT. Now, PET CT is very common in breast cancer and I think in lung cancer. Okay, my colleagues,
Okay, thank you.
welcome. Next candidate.
Assalamu alaikum, sir. I'm candidate number 17.
Yes. Request control.
Okay.
Could you request control, please? Doctor, this patient has fever. Yeah, go on. And one second, this is the only sequence. Some examiner will give you one sequence and you should tell everything. Go on.
Okay. I am provided with a coronal stir imaging
of
head and neck. I can appreciate a normal signal intensity area, predominantly hyperdense in left parapharyngeal location. causing
Okay.
narrowing of the oral cavity at this
Yes.
sorry, at this
Yes.
level.
Yes.
I can also appreciate prominent cervical lymph nodes, predominantly on the left side, one enlarged at the inferior aspect of this lesion.
Yes.
Um, some
What's
scrolling
your
down.
diagnosis? Correlate with the history, please.
There was a history of fever, right?
Yes. So,
Uh, at this point, keeping in view history of the fever, my differential would be parapharyngeal abscess.
excellent. I will help you. See, is this parapharyngeal or abscess or another location?
Sir, I think it is in left tonsillar location.
Excellent. So finally, this
Uh,
is a pre-tonsillar abscess.
abscess,
Thank
yes.
you, doctor, so much. See here, this is DWI. See the central restriction. Thank you,
It
doctor,
is
so
showing
much.
restriction.
Some cases, especially startup case, will be like this. Exactly. Exactly. Okay. Very easy case. So, my colleague, trust in yourself. Really, more than 60% of the Viva is usual cases, and you saw it before. Next candidate.
Sir, can I ask a question?
Yes,
We should mention next steps that I would refer
sure,
this patient in for
sure.
IND, follow up after
Yes,
treatment is suggested.
yes, sure. But يعني,
Yes.
what type of follow-up do you want from a
Follow up
radiological point
after
of view?
NCN and drainage and antibiotic cover for regression.
Yes, see, you will transfer to ENT, and the ENT will do everything. I think no need for again to repeat any either CT or MRI because it is just the peritonsillar abscess. Okay, but you are correct. You should mention the management. Next candidate, please. Hello. Next candidate. Hello. Doctor, leave the mouse, please. Leave the mouse. Hello, Dr. Nagam.
Hello,
Yes. Next candidate. Who is the next, please?
can I be?
Uh, you are candidate 18.
No. I just now volunteer.
Actually, our candidates are all finished.
Finish?
Some of them are
Oh,
absent, so this candidate is joining right now for the last case.
okay. Dr. Nagam, did you have a chance?
Yes, please. Yes, I
No,
had my
no.
chance.
Okay. After this candidate, you will take another chance. Okay.
Okay, thank you so much.
Okay. Welcome. Doctor, could you request control, please? Doctor.
From where? From where?
خلاص, I will scroll for you. No problem.
Okay. Thank you.
This patient, a young 13-year-old female patient, presented with abdominal pain.
I am presented by axial cuts MRI study of the abdomen T2 weighted image
Yes,
in a patient complaining of abdominal pain.
yes,
I am scrolling through the whole exam before I give my comment.
yes.
Actually, there is no obvious abnormality till now. The spleen is normal and liver also, and both kidneys.
Are you sure?
The only abnormality only in the liver, maybe some hypertense foci,
Doctor,
and there is
compare the signal of liver with the muscle. Do you find
it
any
is it is
difference?
It is low in signal intensity compared to the muscle.
Okay, compare the spleen with the muscle. What happened?
So generalized decreased signal involving both the spleen and liver, together with
Okay,
marked hepatomegaly in the coronal
okay.
images.
So what are you thinking about?
I'm thinking about storage disease like hemochromatosis.
Okay, which type? Look at this slice and tell me which type. How many types of hemochromatosis or iron overload?
We have two types. One is primary and the other one is secondary.
Yes.
One type is due to excessive blood transfusion.
No. See. Tell me. The examiner want from you. This is type 1 or type 2 and why? In this image. This is type 1 or 2?
It is secondary hemochromatosis because the
Excellent.
pancreas is not involved.
And
The spleen and liver is involved as well.
And there are another organ involved in this slice.
The vertebra itself.
What? Excellent. So this is a secondary hemochromatosis. Why? There are dark signal. Thank you, doctor.
Yes.
Doctor, in primary type, could you describe me or could you tell me what happened in primary type?
Primary type, I think the liver and the pancreas.
Yes, excellent. Involved. And what else?
I don't sure is the vertebra is involved or not. And heart. Maybe
excellent.
Heart is involved.
See, Michael, thank you, doctor, so much. My colleague, it is very easy. Type 2 is the reticuloendothelial system, iron overload. Very easy. Where is the reticuloendothelial system? Liver, kidney, bone marrow, and maybe lymph node. Liver, kidney, bone marrow. Very easy. Like this is very classic. Dark liver, dark spleen, dark bone marrow. Type 2. But in type 1, heart, non-reticuloendothelial. From the beginning, heart, then liver, then pancreas, then gonads. Okay? Non-reticuloendothelial. Type 1 is due to some abnormalities in the carrier of the iron or absorption of the iron. But type 2 is due to multiple blood transfusion. By the way, this case of a thalassemia, this is the case of case of thalassemia, which has multiple blood transfusion and multiple iron infusion. So there are hemochromatosis. What is the best sequence, doctor, to detect iron in quantitatively? Yani if you wanted to measure iron, by numbers in MRI, which sequence would you use?
I think gradient sequence.
What else?
I'm not sure.
T2 star. There are a specific examination, MRI examination in my center called iron load measurement. Only we do T2 star. And automatically, by some mathematics, the machine give us, this is the expected iron overload in this liver, like this. Okay, by T2 star. Why? Due to susceptibility artifact of the iron. Thank you, doctor, so much.
Okay, thank you.
Welcome. Dr. Nagam?
Yes, sir.
Another chance.
Okay, thank you.
I think yes. Okay. Okay, this is a nice case, doctor.
Okay.
This patient has severe abdominal pain.
I'm presented with a frontal chest radiograph of an adult patient presented with severe abdominal pain.
Yes.
The striking abnormality is elevated left diaphragm,
Yes.
or a curvilinear structure projected over the left lower chest with fluid level.
Mhm.
It is lucent, however, I can see the lung markings going through.
Yes.
No free air under the right hemidiaphragm, no pneumothorax. Okay, the abdomen X-ray shows a well-defined lobulated lucent structure over the left upper quadrant, partially extending into the chest.
Mhm.
Looking for the rest of the abdomen for signs of free air or collections. Not sure about pneumoperitoneum in the
Yes.
central and left part of the abdomen.
Mhm.
Okay, now, given the presentation, concerned about, okay, there is no abnormal bowel loop dilatation to suggest bowel obstruction. This could be, okay, like evolving abscess or gastric torsion.
How to differentiate?
Okay, given if it is a collection, I couldn't see fluid level.
Yes.
If it is gastric torsion, this is supported clinically by the patient having retching and inability to pass an NG tube.
Okay. What is
There
your
is no
next
air
step?
foci along the wall to suggest
Yeah, yeah.
pneumatosis in case of
What is
gastric torsion
your
and
next
ischemia.
step? What is your next step?
Okay, I will ask for cross-sectional imaging, CT scan of the chest, of the abdomen, lower chest and abdomen.
Yes.
Okay,
What happened?
yes, this is gastric torsion.
Okay.
Okay,
What type of torsion?
it is organoaxial
Organoaxial. Organoaxial. Why?
because the long axis of the stomach is inverted. I can see the pylorus
Mm-hmm.
on the other side, I mean reversed.
Mm-hmm. Are you sure?
Not so
Are
much
you
sure.
sure, Cece? Are you sure this stomach is upside down?
Okay, I would like to scroll again and recheck.
See.
Yes,
See.
yes,
This is the
yes.
cardia. Okay.
The cut, yes.
Okay. And
The
this
pylorus
is
is
the
up.
pylorus. The pylorus above the cardia.
Yes.
So what type? What is the type?
So it is mesenteroaxial.
Yes. Very easy, Michael. Thank you, doctor, so much. Very
Welcome.
easy. I will give you one clue to differentiate both types of stomach volvulus. Look at the cardia. Where is the cardia? This one. Or the gastroesophageal junction. This one. Okay. Look above it. There are any pylorus? Yes, doctor. So mesentericoaxial. No any other opinion about, after that. Okay. But if you find this the pylorus in its normal position, yeah, I mean below here, below the cardia, so this is you can diagnose organoaxial volvulus. Very easy. Don't don't crowd your mind by the pylorus will be up and sorry, the greater curvature up and lesser down like this, like this. No, one clue and keep it in mind very clear is more than enough. Again, look at the gastroesophageal junction. This one. Okay, it is in its normal position. Okay, where is the pylorus above it? So this is mesentericoaxial volvulus. Doctor, you forget here in the abdomen to comment at the pregnancy. See here,
No gas in beyond. Okay.
this one. Look at the vertebral column. This. Can you lick?
A fetus, yes. Okay, it's
Fetus.
unexpected, yes.
Okay. Thank you, doctor, so much. This
Okay.
is an
Thank you
urgent
so much,
case.
doctor. Thank you so much.
This case need urgent intervention. We will transfer to the surgeon. In my opinion, don't tell more detail more than that. because the patient is pregnant and the radiologist is here make a fatal mistake. Okay. As the fetus vertebral column is shown here, so this patient wasn't given any apron. This is a fatal mistake. And even she was not asked about her last trimester period or any possibility of pregnancy. Okay. Thank you, my dear, so much.
Thank you.
Study hard. You can do it. Please, again, listen to the record. And if you have time, listen to the GIT, specific GIT that I made before, about 3 sessions, all of them on the YouTube, on my YouTube channel. Thank you so much.
Okay, thank you.
Thank you so much, Dr. Nagam, for your effort yesterday and today.
Welcome, doctor. Thank you again.